So tonight's topic is going to be what is the standard of care and the treatment of misaligned feet? And by misaligned feet, we're talking specifically about a recurrent talotarsal joint dislocation or displacement. That is the true etiology of what leads to hindfoot misalignment for overpronation or hyperpronation. Obviously, if there's a calcaneal varus or something else, it's a different topic for another day. So let's get started. And so where we start here is, what is the orthopedic standard of care? So a patient presents to you with some kind of a concern, and what you want to do is give them a treatment option that's based on an accurate diagnosis that makes sense and is in a matter that's an appropriate course of action for that patient. Because there's not a single form of treatment that works for every patient that walks into your office. Every single foot, every single patient has a different set of circumstances. So that's why we always have to take the entire foot and ankle pathology into consideration. But the first thing that we always want to think about also is that we want to do no harm, or provide a treatment option that has the least amount of harm, but still an effective treatment option. So we have to keep that in the back of our mind. So, you know, and the reason for that whole thing of do no harm, let's say that this patient showed up with some mild pain to her first MPJ. Well, we don't want to just go in and perform a first MPJ arthrodesis right out of the bat. So there's other forms of conservative treatment that we should have tried before we go to the nuclear option with something like this. So again, so what is your ethical obligation when your patients present to you? Well, of course you want to address, so we kind of have a multiple choice here for you. So to only address the pain-related symptoms, to perform an incomplete examination. So if a patient comes to you with an ingrown toenail, that you completely ignore the rest of their foot structure. Or that maybe you do find that there is a pathologic finding, but you don't tell them about that. Or that you only discuss treatment options that are approved by their health insurance policy. So if it's not covered by their insurance, well, we're not even going to talk about that treatment solution. Well, the real answer, of course, is that we want to identify and discuss all key pathologies and present realistic treatment options to your patients, regardless of insurance coverage. So insurance coverage is there as a bonus, but that doesn't dictate treatment. The patient is the one that should ultimately choose what treatment makes the most sense to them. So your responsibility, again, is to establish a great diagnosis, present a range of treatment options regardless of insurance coverage, discuss advantages and disadvantages of the options, provide your opinion as to which option makes the most sense to you as the expert. You're the expert, not them, and not an insurance company either, and to execute that treatment option that the patient selects, if any. Maybe you go through the patient, the options for that patient, and they choose not to go have any kind of care. That's fine. But your job, what is the standard of care, is to give the patient their treatment options. Of course, the patient needs to understand what the root cause of their pathology is and why they've developed any symptoms. They need to understand their options, the advantages, disadvantages, and the patient is the one that's going to choose what option makes the most sense for them at that time. They're going to trust that you are going to execute that treatment option to the best of your ability, and that if any situations that are less than favorable arise, that you're going to be able to handle those. Okay, so that kind of gets some of that kind of theoretical stuff out of the way. But let's get into real case scenarios here. So let's say that this patient presents to your clinic with first MPJ pain. So you take the x-ray, and of course we have a hallux abductus, hallux valgus deformity. We have an increased first intermetatarsal. So are we just going to stop there? Because this is where the patient is having their symptoms, and we're going to only address this deformity and the symptoms associated at this area. Well, we shouldn't just have tunnel vision. We need to take a look at the entire foot structure, and we need to identify that, hey, this patient has a coexisting pathology, or what really is going on is the true root cause to that first MPJ pain. So if we would have just focused our attention on the first MPJ, gave them maybe an injection, they're supposed to wear larger shoes, some things like that, without addressing the underlying etiology, well, how can we expect for this first MPJ pain to ever truly go away? So again, we don't want to just have this finding and limit our observation and our examination just to the first MPJ. So this is why this is so important and why that would be considered below the standard of care. Because we know that there is a true underlying etiologic factor that led to the first MPJ pain. So now let's say that this patient here had an Aiken-Austin bunionectomy. They had pain from the screw from the Austin, so that screw had to come out, and they still have the same pain after the procedure. Why? Well, because the surgeon never addressed the underlying etiology. So why do you think that the pain developed in the first place? So do you think that this would be within the standard of care to completely ignore this whole other pathologic condition going on in the patient's hindfoot? And the answer is no, this should be below the standard of care. So here's another patient who had a Lapidus procedure and also a medial displacement calcaneal osteotomy. She also then had pain from the head of the screw in her calcaneus, so she had to have the screw removed. And within a few months after that, guess what? She still had the same pain in her first MPJ. And of course, to most of you that are already well-versed with recurrent TaloTarsal joint dislocation, you've seen this before, and you understand why it is so important that we treat the underlying cause. I know this video is kind of driving me a little crazy here, but think about what's going on with this patient's foot. This is a dynamic deformity, not a static deformity. That's the problem with traditional x-rays, is that they only give us a static image. It doesn't show the dynamic deformity that's occurring thousands of times a day. So the standard of care is to address all the coexisting pathologies, not just one. So here's this other patient who has jamming in their first MPJ. They don't have any symptoms yet, but would you tell the patient that they have an issue, or would you just ignore this? Or should we allow this patient to continue to walk on a broken foot with pathologic condition until we have significant tissue damage, and now we're going to offer them some kind of surgical option? Or maybe we should have told them that, okay, well, yes, you don't have pain in your first MPJ right now, but we have a pathologic condition that's occurring, and it's only a matter of time before more tissue damage and joint damage is going to occur, and then I'm going to have to perform surgery at that location. So then the patient ends up not going to you, they go to somebody else, and they eventually have a hemi-joint or a total joint replacement procedure performed. And then they end up with complications with the hemi implant or the total implants over here. Now, when the surgeon put these implants in the operating room at the initial surgery, the patient had an excellent range of motion. The position of the implants were absolutely perfect. So why did these implants become complicated like this? Well, that's because of tunnel vision, and that the standard of care truly was not followed, and that the attention was only focused on the first MPJ. Meanwhile, this pathologic TaloTarsal dislocation deformity in the hindfoot was never addressed. The patient never was told that they have a misaligned hindfoot, and the talus is pushing forward against the navicular, which is jamming the first metatarsal into the base of the proximal phalanx, and then that's why we ended up with these complications. So this was not a complete diagnosis. And then we have these newer materials that are seeming to be the holy grail of hallux limitus or hallux rigidus, and guess what? They're also failing. Why? Because again, we're not addressing the underlying etiology. So now what happens to these patients? Well, they go in and they have their first MPJ fuse. This is now the gold standard in the treatment of first MPJ disease, except that we still have the same dynamic deformity that's occurring back in the hindfoot. So what do you think the long-term success rate is going to be? Initially, we're going to look pretty good, but after a while, we still have the jamming that's occurring within the first MPJ, and not that everybody ends up with a complication like this, but it's not the final answer because we still have not solved the complete puzzle. So we're only solving a portion of it. So this just clearly shows when somebody comes in with that first MPJ disease that they get this jamming. And why does that jamming occur? Because of the recurrent TaloTarsal joint dislocation. And there's not a single person out there that can honestly look me in the eye and tell me that this is a normal variant, that this is, that there's no problem with this whatsoever. This is an excessive abnormal motion. We have an instability at the subtalar joint that is then pushing on the navicular and then leading to the jamming of the first MPJ. So this is that dynamic deformity. So this is a orthopedic deformity that created this secondary pathology. And then, oh, look at this back over here. We have a calcaneal spur. And why did we get that spur? Well, something is attached to that structure. We're going to get into that in a little bit. So this study was published in the in 2018, late in 2018, and it looked at patients who had first MPJ surgery and found that almost 93% of them also had a recurrent TaloTarsal joint dislocation deformity. So this is the evidence that shows that there is a coexistence and association between hindfoot pathology and first-rate deformities. And we know this. I mean, it's so obvious. I just showed that to you, but we have the evidence to back up that information. So this deformity began as the patient was a child, and they were told that, oh, don't worry about it, it's going to go away. Of course, we know that that's not true at all. So thousands of times a day, their first metatarsal bone is jamming into the base of the proximal phalanx. The ground reaction forces are pushing up against a weakened first cuneiform joint, and that's why the metatarsal bone is forced up and out. So this should not be any kind of a newsflash to anybody. This is the proven etiology for that. I'm showing it to you right here. So we see that here's a sagittal view showing the recurrent TaloTarsal joint dislocation. This is a pathology that leads, it's proven to lead to many other secondary pathologies. Okay, so this is what leads to tissue strain, and the disease process goes on and on. So now that you know this, and that we have radiographic measurements that we can verify that this orthopedic condition exists, are you going to now ignore that this is there and only talk to your patient about treatment options and their first MPJ without telling the patient, yes, you do have this issue with your first MPJ, but what is making that condition worse starts back here in your hind foot. The talus is partially dislocating on the heel bone, and that's what creates the excessive forces that are now causing the pain in your big toe joint. Okay, so look at this x-ray here on the bottom too. That's never going to go away. It's only going to get worse. Okay, so our due diligence is to tell the patient that that exists. All right, let's shift gears now to the back of the heel and talk about somebody that has heel pain. Plantar fasciitis is a very common condition. It affects millions of people. There's so many different treatments for this. And again, so what I want to talk about is not some rare case of heel pain, but just the run of the mill. They come in with, they get out of bed in the morning, they have pain in their heel. And so the first thing you're going to do is take your x-ray. Why? To make sure that they don't have a fracture of their heel. They don't have any bone tumors or anything crazy like that. So sure enough, there's a little tiny speck of a spur, if you could even call it that, but the patient has the typical heel pain. So because of that, they don't have a fracture. You're going to go into your typical spiel about, okay, well, the plantar fascia is inflamed. We have to give you a steroid injection to calm the inflammation. You need to perform these stretching exercises several times a day. I'm going to make you buy a pair of $800 arch supports. These are custom made for your feet. And this is going to help take the strain off of the plantar fascia. In the meantime, we're going to give you some pills and ice your heel. And then we're going to have lots of prayer. And somehow that's supposed to get rid of their heel pain. And again, you know, there's some patients that maybe they alter their activity level and their heel pain goes away temporarily. But usually it's just a matter of time before the symptoms reoccur. And if it doesn't occur there, it occurs somewhere else. Well, let's take a look at the entire foot structure now. So what's the first thing that you see? Obliterated sinus tarsi. a pathologic talar declination angle. The navicular has dropped. We have an anteriorly deviated simuline. So we have this primary pathology that's occurring above the heel that is now creating the strain on their plantar fascia. And it's that strain that is continuous. So that's why I have this video over here of thousands of times a day, the plantar fascia is being overstrained. And it can deal with it for a while. I mean, it's a healthy structure. But then once patients get into their 40s and the plantar fascia has been overstretched over 70 million times, the poor fascia just can't keep up anymore. And so we develop those micro ruptures. So just think about this patient. You've given them injections, you've given them all kinds of conservative care, but meanwhile, with every step that they take, the same primary etiologic factor is taking its toll on their plantar fascia. How can you consider that to be within the standard of care, not to address the primary etiology of the patient's complaint? We're addressing the symptoms, but we're not addressing the etiology. So that doesn't seem right. So why do we get that plantar heel spur? Well, go ask Dr. Davis with Davis laws. This is a tissue deformation. The plantar fascia is being overstretched. So the plantar fascia is pulling on the periosteum with a medial tubercle, which then feels that pull and it grows out that shelf of bone. And that's why a lot of patients that have heel spurs that never have had a day of heel pain in their life is because that bone spur is accommodating for the strain. But eventually that tissue probably cannot keep up with it, and so the patient's going to develop pain. So the primary deformity is on the top of the heel. The secondary deformity is plantar over there on the medial tubercle. So this other paper was published last year in 2019. And this was a radiographic review of patients who had plantar fascial releases of 101 feet, and it found that almost 94% of those patients had a recurrent TaloTarsal joint dislocation deformity. So that shows that, it's not 100%, but there's no other etiologic factor that is going to have a higher prevalence than recurrent TaloTarsal joint dislocation. So here's a fact for you, that recurrent TaloTarsal joint dislocation leads to a 33% increased strain to the plantar fascia. So we know that overpronation, hyperpronation is the leading cause of plantar fasciopathy. And what causes overpronation is RTT-JD. So this is not just me shouting, talking about this. This is evidence-based when I'm presenting to you. So when we look at the standard of care for the treatment of plantar fascial disease with these injections and ice and orthotics, I mean, there's never been a single study that shows that an orthotic decreases the strain to the plantar fascia. Acupuncture, PRP injections, I mean, those are great about healing tissues, except if we still have the same strain acting on the tissue, how can that be effective? Shock waves the same way. The studies that are out there show that initially that there is maybe a good response, because what does the shock wave actually do? It deadens the nerves. That's why patients have no pain afterward. Their nerves are shut down, and so we're not getting the pain signals to the spine. But meanwhile, the patient still has their underlying orthopedic deformity, and so it's only a matter of time before their heel pain comes back. Unfortunately, what happens for a lot of surgeons is that they don't see the patient's back again because the patient has gone on to somebody else for treatment. So even if we perform a TAL or gastroc recession or any other kind of craziness, we still have the primary diagnosis of RTT-JD. So that's why we really need to address that before we get into these other factors. Is there any evidence to show that HyProCure can decrease the strain to the plantar fascia? Absolutely. Already, back in 2011, I published this paper showing a 33% decrease in strain to the plantar fascia. What's the number one etiology for plantar fasciosis? Is strain, excessive strain. So besides performing a subtalar arthrodesis procedure, we have the only viable option that is scientifically proven to decrease the strain to the plantar fascia. So before we go in and cut somebody's plantar fascia, it probably makes sense that we should stabilize their subtalar joint. So I wrote a book on this that you can buy a copy at thepfmyth.com. and I went through and looked at all of the evidence bases for the majority of treatments and showed why they don't work and why HyProCure with EOTS makes the most choice. It's the best surgical option for patients prior to going in and cutting the plantar fascia, which is there to stabilize the medial column of foot bones. Now, one of the questions that I'm always asked is, okay, well, the patient has no pain in their sinus tarsi, so I should not perform surgery. I need to wait until they have pain there. But that doesn't make any sense. What we're trained to do is to address orthopedic deformities. And this is a orthopedic deformity that probably has a symptom somewhere, even though it doesn't have to have a symptom itself. So we have this diabetic patient here who has lost feeling in their hallux and they've developed this ulcer. So then we should say the same thing for this patient. Well, once you start developing pain, then I'll treat you, but because you have no pain, then I'm just gonna let this go. And of course that's ridiculous because we know that it's never gonna go away on its own and it's gonna get worse. Well, we're taught, and this is what's preached, but there's very few that put these words into action, is that prevention is something that we need to focus on. Let's get to them before they have these end stage diseases, till we can't, till we have to chop off their leg. So we have all these other medical conditions that have absolutely no symptoms whatsoever, and yet we are so focused on treating them. Anybody with high blood sugar, high blood pressure, high cholesterol, we're taking all kinds of medicines and doing everything we can to get those blood levels normal. And that's great, but we need to do the same thing for misaligned feet. Yes, misaligned feet is not a life-threatening condition like this is, for example, but it's still a significant deformity that has a great impact on patients' lives and their well-being. So we cannot just ignore this pathology. It is our due diligence to tell the patient that this deformity exists and that what are the various treatment options for it. That doesn't mean that we're putting a gun to a patient's head and telling them if they don't get a HyProCure put into their foot that they're gonna have a shorter lifespan. Of course not. Our job, though, is to inform them that this deformity is there and that there is a viable treatment option. So that's why we need to shed light on this and not just ignore this condition anymore. We should be done with that. Okay, so we're going through this whole time change now, or this change in the world with this virus that's going on. The same thing needs to happen in medicine and orthopedics with foot and ankle pathology. We can't just ignore this condition any longer. Now, one of the big myths that's out there is the most ridiculous statement in the world of all these pediatricians telling their parents and their patients, don't worry about those misaligned feet. That's normal. That's never ever going to cause you any problem. You're going to magically outgrow it. Well, of course, that's an absolute lie. That's never going to happen. There is no evidence whatsoever to show that a patient with a misaligned foot all of a sudden has an aligned foot. That doesn't make any sense. How is that even possible? With every step that this patient takes thousands of times a day, the talus is partially dislocating on the calcaneus. The spring ligament is being overstretched. The plantar fascia is being overstretched. The posterior tib tendon is being overstretched. The calcaneal apophysis back here is being adversely affected, and patients can end up with Fasciitis. And then we have all the issues to the knees, hips, and back. How can all of a sudden the talus become stabilized and aligned without any outside intervention? It's a bunch of nonsense. What happens? Guaranteed that this is only going to get worse as time goes on, and we're going to develop so many other secondary tissue pathologies. There are literally hundreds and hundreds of published studies that show that they name hyperpronation or misaligned feet, flat feet as the #1 etiology to all these other musculoskeletal deformities. So when you take those x-rays of your patient's feet, you cannot tell me, again, and you cannot tell the patient that this is normal, that this is a normal x-ray. It's not. We have an obliterated sinus tarsi. We have an anteriorly deviated cyma line. We have a pathologic talar declination angle. We have a navicular that's dropped down. Now this patient with this lateral x-ray, this is not a flat foot. So that's why that this deformity is not pes planovalgus. And that's why the topic of this lecture is not what's the standard of care in the treatment of flat feet. It's what is the standard of care in the treatment of recurrent TaloTarsal joint dislocation, because that's what this is. Now, dislocation does not mean a complete dislocation. This is a partial dislocation. So it's the same thing here on this DP view. We have a talar second metatarsal angle that is not normal. It's greater than 16 degrees. This is a pathologic finding. And it's your duty to tell the patient that they have this hindfoot pathology. If the patient walks out of your clinic without you telling them that, then that is below the standard of care. Just like if the patient came in for an ingrown toenail and you didn't say, oh yeah, by the way, you have this big black gangrenous patch on the top of your toe, but because that doesn't hurt you, we're only going to aggress your ingrown toenail. You'd be sued for that every time. I mean, that's just absolutely ridiculous. So we shouldn't wait until this, until we have to use the nuclear option. It's the same thing with recurrent TaloTarsal joint dislocation. Why do we need to wait for the patient to go to end stage to give them this other treatment option? Okay, oh, now you have pain? Great. Now I'm going to treat your feet. Finally, you're 80 years old, so you've suffered all of these years, and now that you have pain, now we're going to do some kind of a treatment for you. Well, that just doesn't make any sense. Maybe 50 years ago, you could get away with that, but because of the internet, patients are becoming more and more educated, and so don't get caught in the trap of misdiagnosing or not disclosing this orthopedic condition to your patient. So when we look at this, we have to not have tunnel vision even just on the recurrent TaloTarsal joint dislocation. We need to ask the patient about their entire body structure, because when the talus slides off of the calcaneus, there's something that's attached proximally to that. So when the talus drops down, that's going to create a functional leg length discrepancy, and this is going to have a negative impact to the knee. So there's, again, hundreds of articles that talk about hindfoot misalignment and its role in creating knee joint instability. So many patients have knee pain. So that's the symptom, is their knee pain, but the underlying pathology that caused their knee pain is down here in their foot. Okay, so this is actually a symptomatic issue. Why do patients end up with arthritic knees? It's an osteoarthritis, wear and tear. It's because of an uneven wear pattern on the knee joint. So the cartilage gets worn away because of the excessive pressure. Why does that happen? It happens for a reason. So, and unfortunately, there's too many people going in to have knee replacements. And yet the problem is that nobody ever addressed the underlying etiology. So what do you think the results of those knee joint replacements are? They're not as good as you think. So there's only one proven option that has been shown to decrease the forces acting on the medial knee, and that's HyProCure. So I published this study back in 2019 that showed a nearly 33% decrease in pressures acting on the medial knee by stabilizing the talus on the calcaneus. Now, of course, this is a ridiculous study. Of course, it makes sense that if we stabilize the foundation joint of the body, that we're going to have positive effects to the rest of the proximal structure. But at least now we can claim that we have evidence basis to show that. The same thing is going to be true for the hip, but it's hard to show the evidence. We have to go in and put sensors into the hip joint. But again, it makes sense that if we prevent the talus from dropping down, that's going to then eliminate the functional leg length discrepancy that pulls the femur from the pelvis that creates the pelvic tilt. Now we go into the millions and millions of people that unfortunately have to go in for back surgery. And what happens after you have one level fused? Well, it's only a matter of time before you have to come back and have additional spine fusions, because once you eliminate the motion that happens at one level, the adjacent levels now have to accommodate more motion. But we never address the underlying etiology of why did they end up having that blown out herniated disc. Well, why do the discs wear out? Because of a pelvic tilt issue. Why do we get pelvic tilt? Because of those misaligned feet. So anybody with the knee, hip, and back problems, those specialists need to eliminate their tunnel vision and look at the patient's feet, and we should offer them a treatment solution that makes sense. I don't think that we're the only ones that know that the feet are the foundation to the body, and that it's the TaloTarsal joint that is actually the foundational joint of the body. So if the TaloTarsal joint is misaligned, you better believe that the rest of the proximal joint structures are also going to be affected. We know that the older you are, then the more likely you are that more and more damage is going to happen. And it's because of the repetitive nature of walking. We think about, your body probably when you're in your 20s is going to be able to withstand the excessive forces acting on the tissues. But the older you get, look at the tens of millions of times we have the excessive strain occurring to those tissues. So they're not going to remain tough as they can forever. And so the older you are, the more likely you are to end up with knee, hip, or back issues. Just makes sense. So when you have a patient coming in with a recurrent TaloTarsal joint dislocation, and they have absolutely no symptoms in their body, well, it's only a matter of time before those symptoms show up. And again, there's papers and articles out there on the internet saying, oh, well, we have athletes that have misaligned feet that never had any kind of pain, and they're playing at such a competitive level. Even Olympian athletes have misaligned feet, and they're out there competing, winning gold medals. But then we don't see them, what happens years later after they've stopped competing. And now they've had hip replacements, their knees are destroyed. Look at the many professionals that are out there, professional athletes, at the end of their careers, where they've had to stop playing basketball because of chronic heel pain. Well, that's because those symptoms finally showed up. So it's not if, it's when. It's never going to go away. So we need to ask our patient about the rest of their body, okay? So every year there's over 1 million surgical procedures performed on the foot. We want to cut the foot everywhere with the plantar fascial releases, with the medial displacement, calcaneal osteotomies, with the Evans, with midfoot work, and that's all fine and dandy, except that we very rarely address the TaloTarsal joint misalignment. And so even after all of this surgery, the talus is still sliding off the calcaneus. We still have the excessive abnormal forces acting on the medial column of foot bones. So that's why these procedures, maybe are pretty good results initially, but we have not fixed all of the broken parts of the foot. So we have to look at the entire foot structure. So even with the ankle joint replacement has always been the holy grail. And we get all these great new ankle implants out there, but nobody takes into consideration about the excessive abnormal motion that's occurring below the ankle joint. So why do we get ankle joint instability? It's because of subtalar joint instability. Then we get talar dome lesions, and then we eventually get osteoarthritis of the talar dome. Then we get a joint replacement, and then it's only a matter of time before that fails because we still have the subtalar joint instability. So growing pains, we have 39 million Americans that have knee pain, and all of these different deformities that occur that are linked back to misaligned feet. So it seems like before we go in and replace somebody's knee, and a patient goes through all kinds of care for their knee, we look at underlying etiologic factors. There are over 719,000 knee joint replacements in 2010. There's 700,000 arthroscopic knee surgeries in 2013. And these are old numbers. Unfortunately, we don't have any new numbers yet. We know that they're going to only increase as time goes on because patients are still walking on their misaligned feet. And the majority of these patients have misaligned feet. I mean, yes, there's other causes for knee pain, but the leading cause is hypermobility that stems because of a misaligned foot. So all these patients that go in with arthroscopic surgery, the literature is already out there saying, don't have arthroscopic surgery. It doesn't work. That's what the evidence says. That's literally what scientific peer-reviewed papers say, is that arthroscopic surgery doesn't work. Yet we spend $4 billion a year on having these procedures. So it just doesn't make any sense. So again, it's just the older you are, the more likely you are to have knee pain. And then we have hip, it's the same thing. It's because of the functional limb length discrepancy. The cartilage of the femur and the hip joint is very strong. It's meant to withstand running, jogging, whatever activity you want to place on it. But if we have an abnormal forces acting within the hip joint, then that's going to cause tissue inflammation, and that's going to be chronic. So we have chronic tissue inflammation that leads to osteoarthritis and eventually to hip pain, and you have to get your joint replaced. So why do we get functional leg length discrepancy? If we measure the femurs and the tibia, they're the same length, but it's because of the talus is dropping down. So the patient's in neutral stance position, they go into relaxed stance position. So the talus is on the calcaneus, sinus tarsi is open, and now the talus is slid off of the calcaneus, and we have an obliterated sinus tarsi. And same thing for the spine issues. They say it's because one side of the spine is weak and the other side is contracting. Well, the contracting side is trying to strengthen the spine. The weakened muscle side doesn't have to work so hard. And again, we talked about the other things here. So we have 62 million Americans that are suffering with back pain, and we know that it's related to those misaligned feet. So musculoskeletal disease is a major economic impact on the healthcare of every government, and it's only getting worse. In 2008, there were over 110 adults that were suffering with musculoskeletal diseases. And for the rest of the world, it's top secret of why they have those issues. For us, we know why they have those issues is because of the misaligned talus. So over $1 trillion is spent treating musculoskeletal diseases. And also this is, there's direct and indirect costs in that $1 trillion because patients have to miss work from having surgeries and having recovery, having to go for physical therapy. So this is a huge economic problem, all because people are focused on the symptoms rather than addressing underlying etiology. So 20% of the symptoms from recurrent TaloTarsal joint dislocation show up in their feet with the stuff we've already talked about with heel pain, bunions, things like that. 80% of the symptoms show up as growing pain, shin splints, knee, hip, and back issues. And then we also have the psychological impact as well, because when you have chronic pain, that leads to depression and just mental issues. Because if one of the treatments for depression is to get out and walk. And when people live in chronic pain, that leads also to chronic depression. So they say you've got to go walk and exercise, but you can't. So this is more than just a physical ailments. These are also related to mental ailments. So we go back again to our do no harm with the standard of care. So it should be below and against the standard of care for any pediatrician to tell their patient to don't worry about those misaligned feet, that your child's going to outgrow it. There's not a single case study showing a patient that has a recurrent TaloTarsal joint dislocation as a child that later in life, all of a sudden those pathologic angles become normal. It doesn't happen. Nobody can say that this is a normal variant and that no treatment is necessary. The literature tells you that you're not telling the truth. The literature supports the theory that this is a disease process. And that's what we need to think about this as a disease, not as just an orthopedic condition. So what's going to happen to this patient, this child? Well, their feet are going to get worse. This poor guy's already had knee surgery, hip surgery, and chronic back pain. He's a diabetic. He can't go out and exercise like he's supposed to because of his misaligned feet. So the do nothing approach actually causes more harm than any other solution, because with every single step, more and more damage is occurring to the feet, knees, hips, and back of this patient. So the only kind of guaranteed results that we're going to get is that you're going to end up with more and more problems throughout your body. So if you do nothing to your feet, risks are ahead, and that's a guarantee. And we get into the whole thing with our orthotics. Now, I'm of the opinion that if you wear shoes, you should have some kind of great arch support in your shoe, because so many shoes just make us walk abnormally. So there's a great and effective place for arch supports. But when it comes to recurrent TaloTarsal joint dislocation, misaligned feet, subtalar joint instability, they're absolutely useless. There is no evidence to show that an orthotic has a positive effect on recurrent TaloTarsal joint dislocation. It is below the standard of care to tell your patient that you're going to make them this device that's going to fix this orthopedic deformity. It doesn't. You take x-rays of your patient standing on it and re-measure their x-rays to show that what your talar declination angle was pathologic when you're standing barefoot, but now that you're standing on the custom-made orthotic, that those angles are back to normal. Of course, it doesn't happen. And actually the literature already has shown us that. There's published data showing that there is no radiographic improvement with the use of a custom-made device. Now, one of the other things is when a patient comes in for that first MPJ pain and you give them the orthotic and say, well, the orthotic is going to prevent your bunion from getting worse, or even better, it's going to reverse your bunion. There's zero evidence to show that. Actually, there's a published paper, two published papers that shows that even after, with the use of a custom-made arch support, that there's a progression of the first MPJ pathology. So to tell a patient that this orthotic is going to prevent or delay the progression of their bunion, there's no scientific basis for that. The science shows actually the worst, that it gets worse. So that's not true. So why? Because we have the same pathologic event here. The talus is still sliding off the calcaneus. We still have the same deforming forces acting on the first MPJ. So there's no evidence to show that these custom arch supports are going to have a positive effect. So, and actually to take it a step further with the do no harm, well, actually it does harm because the patients are wearing these devices with the belief that you've told them that they're going to prevent or reverse the formation of their heel pain or their bunion. And the evidence show that there's no evidence to show that. So that's again, a mistruth. So again, do no harm. So this is from an orthopedic journal, that this is the pre-op and this is the post-op of the patient. And they said that this is within the standard of care. I beg to differ. This is not within the standard of care. This should not be the primary surgical option that this patient is given. This should be labeled with a warning sign that this is harmful. Think about it. You've gone in and performed an Evans procedure and a midfoot. So this patient's guaranteed to get arthritic changes in the calcaneal cuboid and the talonavicular joint, and probably going to end up with ankle joint arthritis as well. So this is harmful. There's other conservative option that could have achieved potentially the same results. So this does not follow the standard of care when you perform a surgical procedure like that. So that brings us to a conservative surgical option that is scientifically based. We have so many published papers that show the efficacy and the safety of the use of HyProCure in the treatment of recurrent TaloTarsal joint dislocation. This shows radiographic and clinically that we have pathologic angles that become normalized once we place the sinus tarsi stent into the patient's feet. We also have so many papers showing that we have decreased strain to the plantar fascia, to the posterior tib tendon, and then also to the knee. So it's time to take the blindfold off and let the blind see, to look at the entire foot structure. And we need to get the message out there that if this patient has an unstable talus, that it's not a good thing and that we need to stabilize it and take that preventative treatment measure. So with an effective treatment that works. So that's why EOTS with HyProCure is the only solution that's proven when indicated. I mean, obviously this isn't a solution for everybody, and patients need a lot of other solutions a lot of times also. So you can have RTGJD with other co-deformities, but this accurately addresses the underlying etiology. So we want to offer our patients real solutions, not Band-Aids. So, and we want to create a positive change. This is not just better for our patients, but when we fix their underlying pathology, then this is going to help with the economy, with their mental health, with their physical health. There's so many amazing things. So that's why each of us needs to get out there and do what we can in our part of the world to make this positive change. Now, again, we're not going to force a patient to have any kind of a treatment. We never convince a patient. We are only there as a consultant to say, this is what I found. These are the treatment options that you have. Here are the advantages and the disadvantages of each of those treatments. And this is the best one that I feel would work for you. And that's the end of it. And it's up to the patient to decide from there. So that should be within the standard of care. Again, it's to address the root cause of the patient's concern. And that doesn't mean only to address the symptoms. And then we want to have an effective, proven treatment solution that makes sense for the patient. So does it fix the pathologic process and that it does no harm? When we go in here and do a medial displacement, calcaneal osteotomy, and Evans and midfoot fusions, those are great procedures, but they do harm. There are so many risks that are associated with those procedures. And especially the talus is still not fixed. So we've done all these surgeries, but yet the talus is still broken. We have TaloTarsal instability. So we could have just done this conservative option. We could have tried this. I'm not guaranteeing a patient that this is going to work for them because there's no such thing as a perfect procedure. But before you go in and perform an irreversible procedure, the standard of care says that we should try a conservative option. So this is what orthopedics are based on. So that which is unstable, make stable. That's a pathology. So we want to stabilize it. That which is crooked, make straight. And we want to have a joint preservation procedure over joint destructive when possible. It's not always possible, but when it is possible, that's what we should try. So that's my presentation here on the standard of care. I hope that this was informative. I know my dog is barking in the background. I apologize for that. Hopefully that wasn't too distracting. We do have two questions that were written in here. And the first one is that medial arthrosis is not associated with flat feet. And I guess that's talking about with the knee arthrosis. And sure, I agree that not everybody that has arthrosis of the medial joint has a flat foot. But when you take a look at the x-rays, most likely they're gonna have hindfoot instability. So that's why we wanna take a look at the x-rays of their feet. And we should begin the process there because that's where the excessive motion is going to start. So we have to begin at the hindfoot misalignment. That's where the excessive motion starts that's going to cause the knee to twist. The knee doesn't twist, and then we have the hindfoot misalignment. But we look forward to hearing from you. Please email us at info@gromedica.com if you have any other questions. And always you can visit HyProCureDoctors.com as well. Thank you so much and have a great evening.